Hounchell, the VP of Product Strategy and Management at UCare. For those who don't know, UCare is an independent nonprofit health plan providing healthcare administrative services through the end of 2025 to 600,000 members throughout Minnesota and parts of western Wisconsin. Since then, UCare has transitioned its Medicaid and ACA membership and product lines to Medica. Dan, thank you so much for joining us today.
No, thank you for having me. Excited to be here.
So let's talk about this transition. I think I understand that regional health plans may be in trouble, and you said UCare may be a canary in a coal mine in receivership. Went from $6 billion in revenue in 24 to $0 now since it's been transitioned to Medica. So talk to me about it. How did you end up in that space, and then I think I'd like to move into kind of actions to have prevented it, potentially with analytics, but we'll get there. So just talk to me about what's been going on and how you think this might be a national trend.
Yeah, no, I appreciate you asking. It's a big question. It's a loaded question. There are a number of different factors. I mean, UCare, like a lot of regional health plans, heavily reliant on government programs, and whether it's Medicaid, Medicare Advantage, et cetera. Medicaid in particular, from rates that were set by the state, have been challenging and really disadvantage organizations, I think, like UCare. But that being said, like a lot of regional plans, UCare was looking to diversify and not just be tied to one state or one region, but expand elsewhere. And there is a lot of resources, time, and sophistication that's needed to expand into other states, whether it's Medicaid or other lines of business. And that's really hard for regional plans to kind of scale up and be able to do that efficiently, as well as just overall managing a book of business during what the industry has seen on the health insurance side of really high volume, high cost of care, a lot of things coming out of the pandemic and, emerging trends and skyrocketing MLRs, et cetera. The analytics that a regional plan needs to be able to dig into this and make actionable steps is a real challenge because, regional plans are kind of, doing a lot of stuff with rubber bands and paper clips and, whatever they have to do to get by because they're nonprofit. Every dollar they make goes back into the community kind of thing. But when you get in hard times like this, there needs to be a strategy of how are you going to invest in the analytics infrastructure and care management infrastructure to be able to manage enough to get through these lulls that come and working in health insurance.
So Dan, I appreciate you bringing us into the analytics portion of the conversation. You said that though there were outside industry factors, for example, reimbursement rates in Wisconsin or Minnesota, and reduction in Medicaid funding from the federal government, so therefore it wasn't all UCare's fault. You did say that UCare may have overplayed its hand strategically, and actions may have been taken that could have prevented its insolvency if they had some quick and wise investments in analytics to generate potentially real-time analysis of performance of its provider network and product. So that's a whole lot of preamble to ask you, what sort of top data points do you wish UCare had access to last year that might have prevented insolvency, and instead of taking you down to a receivership, instead might have increased your profitability?
Yeah, I think you hit the nail on the head with that question. The tricky thing, right, about being a health plan and health insurance is like everything that you look at is almost like 3 months in arrear, right? Because claims come in and you're always kind of looking retrospectively at things. And then you also have to realize if you're seeing a trend Q1, that's probably going to exacerbate itself and be even worse Q4 kind of thing. And so just knowing that you're always looking at the very, very least 9, 12, 15 months ahead, maybe even 18 months ahead of like where's the trend going. And so if you don't have the type of data tools to be able to, when you get those initial red flags of like, hey, our risk-based capital is looking a little bit out of whack, or we're seeing really high increase in utilization with key providers or key segments of services being delivered, that if you can't, one, identify those right away, because again, you're looking 3 months in a rear at least. And then if you're not able to like take action and realize, here are the things we do, because every action you take probably takes 3 to 6 months to implement.
Hmm.
So I don't know if this makes sense, but just to try to simplify it, is that if you don't intervene at the very moment that you understand what the potential issue is and what's going on, and implement action steps, then you're probably 6, 9, 12 months out before you actually see any results of anything you're doing. And at that point, it's too late. I mean, that's how you go from 6 billion to $0 in 12 months, is that it's just, you can't hesitate. You have to have good data at the time you recognize there is a significant issue, and you have to be able to implement steps to correct those issues, renegotiate contracts with providers, vendors, et cetera. Better leverage what your value-based care agreements look like. If you don't have those analytical tools in place to do that more real time, um, in challenging times like this, it's really, really difficult for a regional plan to do it. Because if you're a national plan, you've got leverage, you've got size. They took hits, they lost a lot of money too, but they could bear it, right? Your regional plan, the margin for error is so much more smaller. And so you have to take more immediate action and have more timely data.
So, Dan, you're begging the question, why didn't the executive leadership team at UCare take preemptive action to renegotiate contracts to kind of obtain some kind of analytical solution that provided more real-time insight into the trends affecting their user base, and what kind of data issues were preventing these insights from being arrived at in a more real-time manner?
I wish I could say it was like pretty straightforward and it was just, lack of attention to detail or something like that, but that was not the case. It was more complex than that. And, it goes back to prior years, the nature of some of these government programs not being diversified in your portfolio. There's data issues that in terms of what's relayed and received with the state, with CMS, et cetera. And, quite frankly, again, regional plans have to do things in a very cost conscious manner. I'll put it that way. And
Hmm.
so, investing in the technologies that are out there, I don't know if they're as readily available as they are now,
Hmm.
especially with the advent of AI and how those tools are, more affordable to plans of all size. I just don't know that they were there at the time. And so, again, a number of different factors: technology, the nature of government programs, and also just not having ever been in this situation before. You don't know what you don't know at some point.
So let's go back in time and say that right now, instead of in June of 2026, you're the CEO of UCare and we're in June of 2024. Knowing what you know now, what decisions do you make to preserve the future of UCare?
So you're asking, if it's June 2024, what would I have done differently? I
What could
mean,
you do
it's
now as CEO in 2024, knowing exactly what's going to happen in the next 2 years?
Yeah, I mean, it's hard to play Monday morning quarterback. I
Yeah.
mean, well, it's not hard. Actually, it's easy, right? But in the moment, that's a tough call. I think just being aware, I would just say to anybody, like, it's time tells that when you're in the health insurance industry, there are peaks and valleys,
Hmm.
and we are in or have been in a pretty significant valley with the cost of care and kind of what we're going through. And I think when you're at the peak, you just need to make sure that you're preparing for the worst. And nobody wants to hear that, but when it's riding high, just making sure not to overextend oneself, but also taking the opportunity to reinvest in kind of fundamental infrastructure to make sure that you can anticipate what's going to come, deal with what's going to come, because again, it just never fails. If there's a peak in health insurance, there's going to be a valley, and you just have to be prepared to ride that out and make sure you make the right investments when you're at your peak revenue
I'd, I'd
times.
like to double click on the data issues that we were speaking of. If you, I'm just going to present some hypotheticals. Suppose you had access to real-time integrated clinical and claims data in the cloud that's aggregated, normalized, deduplicated, and that information, instead of just being limited to an ADT message, maybe through national network connectivity or some other kind of subscription, provides you real-time clinical information on all your 600,000 beneficiaries, and marries that with claims data when the claims data becomes available. Is that the sort of solution that you'd be looking for? Also, what kind of analytics solution would you think best be leveraged to kind of gain the insights that the leadership of health plans would need?
Yeah, no, I appreciate that. Actually, it's a very good leading question. And so I would say that, yeah, absolutely, that information. And to make it more practical is how can you bring that to the table in, let's say, a joint operating committee that you typically have with different health systems and managing value-based arrangements, which the majority of your contracts are. How can you bring that to the table? And that analytics to discussions with the state or even with CMS to show where the opportunities and gaps are, whether it's clinical, whether it's types of utilization, inpatient, outpatient, pharmacy, et cetera. Again, being able to show something quote unquote more real time or within the last few months versus like, hey, it's end of year and here's what we saw, and this is
Mhm.
not really good. And there's no opportunity to take action on it. And there are
Mhm.
solutions out there, right? I mean, I think a lot of people turn to the likes of Optum. There are other, strong performers like Spectromedics out there. There are, just a host of solutions like Milliman and others that provide some different insights on this front. And if regional health plans are not making the investments in those solutions, it's
Mhm.
going to be a real challenge to dig out of this valley.
Do you think, given the financial challenges facing regional health plans, perhaps pricing of these analytical and real-time clinical data solutions might need to take into account the financial realities facing the plans by moving, like, not front loading a capital cost, but maybe shifting delayed payment or operational payments? What kind of things could Milliman or Spectrum or other kind of vendors do to have made their solutions more easily digestible by UCare?
Yeah, that's a really good question. I honestly, I think it kind of changes by the day. Again, I think with the more integration of AI solutions, it's getting more affordable by the
Mm-hmm.
day.
Mm-hmm.
And so, and the ROI becomes more apparent by the day as well. So, take for example, whether it's Spectromedics or Optum or somebody, you might spend several $100,000 to implement a solution like this over 3 or 4 months time to get that level of analytics we've been talking about. But at the end of the day, that might save you, and nobody wants to hear this, but it might save you 3 to 4 employees that you have to hire on the analytics side to put together more than rote and manual spreadsheets or whatever the form is that people share this analytics. And it's like instantaneous when you implement these solutions. It's giving ready recommendations and helping leadership understand like what are the key items to focus on literally minutes before walking into a meeting type of thing, whether it's with providers or senior executives, et cetera. Like just being able to have that kind of data at your fingertips would have made a huge difference for the likes of UCare or I would guess Providence and others that have gone down this road recently. And I think other regional health plans that typically have not had this type of tool or resource in the past.
So I'd like to kind of there's a message that health plans and providers are hearing from Dr. Oz at CMS, HHS, and the White House, which is waste, fraud, and abuse is something that's rife and rampant and affecting plans and providers. Do you think that there's was that a contributing factor to the receivership that UCare is now in? Do you think there's something that needed to have been done to identify more waste, fraud, and abuse and cut it at the head, or do you think that mostly it's just focusing on kind of renegotiating contracts and getting the right tools in there to know where to take action?
Yeah, it's a great question. I mean, fraud, waste, and abuse has always been and continues to be an issue in healthcare. I mean, if there's an industry that sucks up 20% of your GDP, I mean, it's going to be ripe for FWA
Yeah.
types of items. So I just don't think that's going to go away. Do I think it was a big contributing factor to UCare and its demise? It certainly played a role, but I wouldn't say that was a key contributor.
Hmm.
Could there have been more done, by various different parties? Sure, there always is. But I don't think it was a driving force. I think the efforts that CMS and others are undertaking on this front, it's the right thing. There needs to be more done on this, but at the same time, it's not the end all be all in terms of why we're seeing some of these situations.
So, Dan, we only have a few more minutes left of this episode, and our listeners may be thinking, okay, so maybe I am a small health plan, or maybe I'm a provider organization, but we work with some of our patients are covered by small regional health plans across the country. And this message that Dan is sharing with us is actually concerning. It's unfortunate what happened to UCare, and we'd like to prevent that from happening to our regional health plan. What sort of steps do you think either Medica should take now that they've taken over UCare, or XYZ small regional health plan across the country should take? You mentioned that there needs to be more real-time clinical access to clinical data, and you need to have an analytical platform. Kind of, what are some of the interventions you think that the analytics platform may allow you to take, or what kind of steps might our listeners be able to take in order to save their regional health plans?
Yeah, I mean, if I knew like the key answer to that, I'd be a very rich man. But no, you're spot on with the question. I- it comes down to regional health plans are very unique in that they have very strong relationships with their providers that they work and contract with, and they've got very strong ties into the communities that they work with. If they are able to provide more real-time data and more transparent data to those partners that they have in the community and within a provider community as well, that
Hmm.
they're going to be able to collaborate more so than maybe a national health insurance company can, to impact, gaps in care, where utilization is, maybe not trending the way it should be for different services, and really help control the overall total cost of care. Again, having that data, being able to leverage those partnerships and the strengths that community and regional health plans have with those within the community and with providers is going to be a really big deal for them, I think, in the years to come. So
Just
those investments are going to be a big deal.
to
Yeah.
understand exactly what you're saying in terms of collaborating with providers, if you had this real-time data and you could have 2 years ago gone to providers and said, we're in danger of going out of business for the X, Y, and Z reasons, would you wish that the providers would have said, oh man, we really need you here to support our community. We are willing to now accept lower reimbursement rates in order to prevent your insolvency? Or are you going to say instead, oh, us providers, we're going to look to improve care management with A population, B population, and C population, with which your analytics have identified as being really in a position to benefit from improved care management? Is it both, or one or the other, or something else?
I think it's the latter. I think if you get into I think part of the issue is that if you get into like, oh, I need lower reimbursement rates. So if I'm looking at more per click payments type of
Hmm.
scenario, like it's a no-win situation for everybody at the end of the
Hmm.
day, and from that standpoint. So it has to be of like, hey, how can we better manage the total cost of care, increase quality, and have make sure we're paying for the right types of utilization versus of like, hey, I'm just going to cut your rates.
Hmm. Okay, thank you. I appreciate your time on our call today. For our listeners, this has been Dan Hounchell from UCare, the VP of Product Strategy and Management. Dan, thank you so much for your time today.
No, I really appreciate it. Thank you.